have access to the PowerPoint that I had sent that we could put on the
Uh,
screen?
I can get it. Yeah, if you want me to.
Yeah. Yeah, that would be great. I'd appreciate it. But
You don't
for
have.
that, I just want to go over, pardon?
Usually we have you share it, but I can find it. I'll find it.
Okay. I usually it's whoever's organizing
Yeah,
it
well that way
can
that
give
well
me
see if we
access.
do it that way, you can control it. Otherwise, you have.
Yeah,
So
I don't know if I have the ability to do that on
all right, I
the
have it.
computer. Okay, great. Okay. Well,
Um,
before we get started, just let me reiterate the objectives. The topic is traumatic brain injuries amongst military service members and veterans. And the objectives are a better understanding of the correlation between TBIs, mental health, substance abuse, and suicide. Another objective is to learn about accepted Department of Defense, Department of Veterans Affairs, and private sector TBI interdisciplinary models of care that continue to evolve over time. And the third is some of the medical and moral imperatives that need to happen for there to be a paradigm shift in TBI treatment. And I think all of us that have been in this space or have had patients that have had invisible wounds, oftentimes the clinicians have been trained to more often than not treat the symptoms versus the underlying causes. Can you get that those slides up, Bill, please?
yeah, let me. So I have it. I have it. Hang on. I have it this way. Will that work for you?
I can't see it, but oh yeah, there it is. Okay.
I mean, will it work this way, or I can probably I'd have to do something to get.
Um,
Will that work that way, or no? Is that not? Is that too?
that's not, that's, I don't think that it's large enough to actually see.
All right. So give me a few minutes here to.
Okay. And while you're doing that, just a disclaimer that I'm not representing any organization. I'm not being compensated for this presentation, and the topics that I'm talking about are based upon my own research, my own professional experiences, and I just wanted to make sure that everyone is understands that. So, thanks.
Getting there. How's that? You see a whole screen now?
No, it's still pretty small.
What about now?
There you go.
How about
Perfect.
you got it? Okay.
Yeah, that works perfectly. Thanks.
Right. So you tell me when to advance.
Okay, yeah, just yeah, if you can go to the next, actually the next slide, and then we'll start with the other slide, the next slide here. So, yeah, now that's nothing. I want to say a couple of things. One is that um, I've been very fortunate to have a lot of different careers over the last 40, close to 50 years, and based upon those experiences, working in VA healthcare, DoD healthcare, working at the county level with the Florida Department of Health, working in academic medicine. It's really given me a lot of tremendous experiences that I think have helped me understand what some of the real challenges are for our clinicians when it comes to treating those with traumatic brain injuries. And I know this is somewhat remedial from this target audience as it relates to what is a traumatic brain injury. But I think what's important to note is that as we continue to learn more and more about invisible wounds, we understand now there's a lot of different experiences and events that weren't at one point in time thought to cause any kind of brain trauma. And I think when we look at the military, you look at how they train with their exposure to heavy artillery. There's a lot of blast overexposure. There's a lot of repetitive trauma that the brain experiences from training evolutions. Just recently, there's a lot of challenges right now with a lot of former Navy fighter pilots as they would take off and land from aircraft carriers. The abruptness, parachute jumping over time. There's a lot of things that we never thought caused brain injuries, but now we're learning more and more about that. Next slide, please. Here's I think probably one of the biggest challenges when it comes to the medical imperative of really looking at how to really diagnose an individual, because a person with a brain injury, it's invisible. What you'll see is that they look healthy. There's no physical injuries. They talk and walk with minimal issues, yet underneath, there's visual disturbances, there's memory problems, there's dizziness, there's pain and discomfort, cognitive fatigue, trouble communicating, and balance issues. Yet, when a person presents themselves to a primary care provider, the likelihood is that primary care provider will refer them to a mental health professional because of the symptoms that they believe are more in the mental health arena, that's more psychological and physiological. And unfortunately, when that happens, a lot of people, and certainly with the veteran and military communities, they're prescribed a lot of different types of meds that oftentimes are counterproductive to their traumatic brain injury that has been either misdiagnosed or not diagnosed. And that often leads to a downward spiral, which in many instances, unfortunately, a side effect of a lot of those medications is suicidal ideation. And regrettably, a lot of veterans and service members die by suicide because of that. Next slide, please. What happened back in 2007, 2008, at the height of the Iraq and Afghanistan wars, the global war on terrorism, the overseas contingency operations, is more and more of our warriors were coming back with behavioral changes. And the military health system didn't quite know how to deal and handle those individuals that came back. Because as I alluded to in the previous slide, they looked fine, they spoke fine, but their behavior had changed significantly. And more often than not, they were diagnosed with post-traumatic stress disorder. Well, in 2007, the Fisher Foundation has heard that there were a lot of individuals that were getting discharged from the military or actually getting discharged under less than honorable conditions because when they came back from a deployment, they weren't the same person that they were prior to. So they gifted the Department of Defense $70 million to open up the very first National Intrepid Center of Excellence out of Bethesda, specifically for invisible wounds. This is the type of model of care that the NICO, National Intrepid Center of Excellence, started back in 2010, 2011, when they first started seeing patients after the brick and mortar facility was completed. And if you think about looking at anybody with an invisible wound, there's no cookie cutter approach. It's trial and error, and everybody responds differently to different modalities. And so this is a model of the interdisciplinary model of care that was started back in 2010 when they first started seeing service members at the NICO in Bethesda. Now, the founding director of the NICO is a behavioral neurologist named Jim Kelly. Jim's career was mostly in the world of academia, but he also was the neurologist assigned to the Chicago Blackhawks and had done a lot of work on concussive protocol for NCAA. So he was highly recruited out of the world of academia to be the first founding director at the National Intrepid Center of Excellence. He was there for about 6 or 7 years, and he's the one that developed this model of care. Next slide, please. There's been a lot of studies that have been done on those service members that have gone through the NICO, and it's a program. It's a 30-day program. It's like it's not a complete inpatient program, but it is a program where the individuals are participating for a 30-day period. And all of these types of treatment modalities were evaluated. And for the first 3 to 4 years, about 1,200 service members went through this program. And over 90%, not only was the satisfaction score excellent, but most of them were able to stay in the fight, which means they were not determined to be not physically qualified and medically discharged from the military. So that in and of itself was a huge change in what had been the norm prior to the National Intrepid Center of Excellence becoming part of the military health system. Next slide, please. In addition to the National Intrepid Center of Excellence, which is focused on those that are still in uniform, there's a lot of different programs specifically for veterans that are challenged with invisible wounds. And as Bill alluded to, the Avalon Action Alliance, I've been part of since day one, prior to that becoming a network that is located now in 6 different locations. I was the chief operating officer and chief of staff at the very first veteran-centric traumatic brain injury center located at the Anschutz Medical Campus in Aurora, Colorado. And the model of care that was started at the National Intrepid Center of Excellence is replicated at all these sites. And Jim Kelly was the first person that started the veteran-centric using the model that he started when he was at the NICO. So Jim was the first executive director for the Marcus Institute for Brain Health in Colorado. That's part of the Avalon Action Alliance network. And the other sites are using same protocols because we're doing a clinical study now to determine the efficacy of this treatment model. And we've seen a lot of real positive results. There's been a lot of research and a lot of clinical studies already published specifically on this model of care. Another model of care is with the Wounded Warrior Project, and they have 4 Warrior Care Network sites. One's at UCLA, one's at Emory in Georgia, one's at Rush in Illinois, and one's with affiliated with Mass General in Massachusetts. And those 4 sites do a lot of the interdisciplinary model of care, but with the exception, I think, of Boston, the Mass General, the other facilities focus more on the mental health, whereas the Avalon Action Alliance network focuses on the primary condition of a traumatic brain injury and the comorbid conditions associated with that as it relates to mental health, substance abuse, and hopefully suicidal ideation if that's the case. So it really has worked out very, very well that these programs have done tremendous work to help veterans that are really challenged with invisible wounds. Just as an aside, the Avalon Action Alliance came to fruition from a gentleman named Bernie Marcus. Bernie Marcus was one of the co-founders of Home Depot. He passed away last November at the ripe old age of 95. But he donated $38 million for us to start the very first veteran-centric interdisciplinary model of care in Colorado. And fast forward, his partner, who was also a co-owner of Home Depot, is Arthur Blank, the owner of the Atlanta Falcons. So between those two and the Gary Sinise Foundation, we've been blessed to probably get about $100 million of philanthropic funds for that very program. And the Wounded Warrior Project, they have done exceptionally well fundraising. I think we've all seen the commercials on TV. They're a $300 million nonprofit, and they've been doing great things to help our warriors and their families over many, many, many years. Next slide, please. Here's an alarming statistic. If you look at just the bullets on the left, that in and of itself is alarming. But if you take a look at this slide, and this was published in the Journal of Neurology, I think it was in 2022 or 2023. If you look at the suicide rates of veterans with TBIs, it went in a 15-year span from less than 10 per 100,000 to over 90 per 100,000. And the veteran population at large went from that 6% to almost 60,000 per 100,000. As you can see, the adult civilian population has remained stagnant over that period of time as it relates to those that have died by suicide. That's an epidemic, and it's been an absolute challenge to get our arms around why. Every year, the VA and DoD allocate millions and millions of dollars towards suicide prevention. Yet, there's really been absolutely no changes, and if in fact it's gone up over the years. This is, and so most of the funds that go towards suicide prevention have gone towards the mental health aspect of it. And my theory is that when you talk about 18, 20, 22 veterans that die on a daily basis from primarily self-inflicted gunshot wounds, I think if you peel the onion back and you were able to do a forensic autopsy on their brain, that a good number of them had had a brain injury that was misdiagnosed or never diagnosed and had the same scenario that I alluded to earlier: mental health, psychotropic meds, suicidal ideation. When you're dealing with traumatic brain injury, as the slide alludes to, the significance of being addicted to and having substance abuse issues, whether it be alcohol, whether it be drugs. In most instances, it's a combination of both. Because that brain is not working properly, the person masks their pain by taking the drugs and the medications, and it has oftentimes it has a fatal effect. But that's an alarming statistic. Next slide, please. So one of the things that has happened, and I think everyone on this call has probably done a lot of work and continues to do a lot of work on some of those non-traditional TBI modalities that have become more and more popular over the last several years. I met Mark Gordon at a brain summit a little over a year ago in Tampa, and he gave a presentation, and afterwards we got to chatting, and fast forward, we've become good friends. But I really have done a lot of research on his protocol with Millennium Healthcare, and conceptually, it makes a lot of sense that if there's a chemical imbalance in the brain that's causing the brain to be inflamed, until that brain is treated effectively with the chemicals and having hormone levels that are conducive to what the pituitary gland should be producing, the likelihood is that they're not going to benefit as much from all the other modalities unless or until the inflammation is eradicated or minimized. And so I think, and I know, Bill, you do a lot of hormone, you see a lot of veterans. I'm guessing that there's a lot that probably have low levels that.
Yeah, I'm one of Mark's proteges, so from almost 10 years now. So.
Okay. And so I really do believe, I do believe that that's a real big issue for all of those that have an invisible wound, even if it's not a TBI, if there's inflammation in the brain in some way, shape, or form because of stress. I mean, who knows? But I do think that that's the key to all the other different modalities that are available. And as we all know, there's a tremendous amount of energy right now on hyperbaric oxygen therapy for traumatic brain injury, mild traumatic brain injuries. In the state of Florida, they've allocated $25 million to do a clinical study on veterans at the University of South Florida, and that's in year 2, to see what benefits exist there. Also, transcranial magnetic stimulation, that has also been a modality that the state of Florida is funding for any veteran who might benefit from TMS, to be able to go to various different clinics throughout the entire state to get that modality. I will say that I don't think that there's really any one modality that will ever do what everybody would hope it would do, and that is address the issues as it relates to invisible wounds. I think it's always going to be a model that includes multiple different modalities, some of your traditional mainstream medical modalities, but also some of these other modalities that are becoming more and more popular. And photobiomodulation is another big one. There was a Heritage Foundation PBS special on May 1st that spoke about the benefits of photobiomodulation and hyperbaric oxygen in the treatment of traumatic brain injuries. And then in chiropractic care, cervical chiropractic care, that's getting a lot of traction as well. And then just in the last few years, the psychedelic assisted therapies, ketamine treatment, there's a lot of studies going on right now. VA has allocated millions of dollars for a study that's going on now up in the Northeast on psychotropic meds under obviously a very monitored setting. And DOD, in their budget, allocated $25 million. And that's being piloted at the Walter Reed facility in Bethesda. So there's a lot of traction going on with that. I just got notified a couple of days ago that there's a $735,000 gift or grant from the state of Florida for a ketamine and a protocol involving ketamine and using Mark's protocol for a clinical study. So there's a lot going on as it relates to getting more exposure to some of these models that unfortunately aren't embraced by mainstream medicine in most instances. Next slide, please.
You should have been.
I'm sorry.
You should have been around the first time we tried to get a hormone panel done from the VA in Reno here. You should have heard the 4-letter words hurled at me. But that was 10 years ago. Now we're kind of accepted, actually. So,
I think things have changed, but I still think that there's a tremendous amount of pushback, and these are some of the things, the moral and medical imperatives. I think there's a tremendous amount of pushback in the world of academia because there's not decades and decades of research and clinical studies to validate and verify the efficacy of a lot of the modalities. And I also think, as I mentioned here, I'll just kind of go through this list, state and federal legislation and policy changes. I think just January of this year, CMS now identifies traumatic brain injuries as a chronic condition. It was categorized as an acute condition before that. And I think that will help over time, and hopefully with healthcare reform, so that a lot of the modalities that are clearly benefiting patients with TBIs will become an accepted modality for the purpose of getting reimbursed. And I'm really hoping.
Our mic drop quote, at least mine is, where are the hormones generated from? What organs?
The pituitary gland?
The pituitary, the hypothalamus and the pituitary, correct? Mm-hmm. That's where most of them originate from. So if you shake those up in some manner, what do you think's going to happen? Right.
And especially if you have an incident, if you are within a certain distance of an IED explosion, which is about 25,000 miles an hour, and it literally rocks your head and lifts you off the ground, and within seconds you have 2 significant brain injuries, right? Which has happened frequently over the last 20 years.
Right. The hypothalamus only has two thin nerves that innervate it with no blood supply, and the pituitary has two very tiny arteries. It doesn't take much to tear them. And okay, and
Yeah.
then what we need to do is teach you what to look for in hormone excesses and deficiencies. And once you know that, it all makes sense.
It makes a lot of sense. A lot of sense. One of the things that has happened, it was last August, where the secretary, the deputy secretary for DoD came out with a policy on changing training and initiating baseline cognitive testing for all new recruits in the military and for all those that are serving in what are called high-risk designators. And I think that's going to be really important to mitigate the kinds of TBIs that we've been seeing over the last 20 years. I think another thing that is important with VA is, and I've been fighting with VA, even though I work for VA, I've been fighting with VA since 2018 when they passed it's called the Mission Act. And that Mission Act is supposed to allow veterans to get more care in the community if they so choose, if they meet one of 6 criteria. And it has failed miserably because the VA has pushed back time and time again. And I mean, I love VA. I think the quality care is good, but when you have changes in leadership every 2 or 3 or 4 years, you don't get that kind of synergy over time because everybody has a different agenda when they become a leader if you're a political appointee. So that's been a real challenge. But I do think that there's enough traction now, and there's a lot less rigidity in the VA healthcare system than there has been in years past. And one of the things I like being at this stage of my life is I don't have to worry about getting fired. I don't have to worry about getting promoted. So I don't have to be politically correct. And I leverage the things that I think are tremendously important for the cultures to change within DoD and VA to the degree that, when I'm on Zoom meetings and speaking to high-level officials or our political appointees, and also with our lawmakers, I tell it like it is, because I think that needs to be done. I think the other thing is if we look at our healthcare system, it's so stovepiped. You have your primary care provider as your navigator. You get consults to here, there, and oftentimes it takes forever to get all these consults to be seen, but they lose the synergy with the model of care that has been promulgated since 2010 at the National Center of Excellence. That interdisciplinary model of care, every single one of those clinicians communicate with each other every single day. Every time a patient is in the program, before the patient even gets there, the entire team thoroughly reviews the medical records. And when that patient gets to the center for treatment, they have what's called a fishbowl, and that is that individual has a meeting with the entire clinical team at the same time and tells his or her story just one time. And to me, I'm sure we've all experienced, well, why are you here for me? Like a lot of times the healthcare system doesn't allow for the time that's needed for clinicians to really do a thorough review of their patients in terms of reviewing the medical records and knowing enough about them before they come to an appointment to be able to address the issues that are at that time, as opposed to asking them the same questions over and over again. I think another thing is when you talk about TBIs, it's almost always talked about under the umbrella of mental health. And I believe that it should be a separate autonomous condition because it is physiological, not psychological. But everyone that has a brain injury that I've ever seen has always had behavioral challenges. And so I really think it should be in its own category. And I think a lot of the things that have caused some of the modalities that I alluded to in a previous slide, and obviously Mark's and I think yours as well, Bill, and I'm sure others on this call, is that big pharma has had such an impact and influence on our healthcare system. And I'm hoping, irrespective of your political viewpoints, I'm hoping that with this administration that there'll be a lot of changes so that big pharma does not have the same clout in the future as it has had in the past, because I think it's been, in many instances, very counterproductive. And I think when we talk about healthcare reform, you know, people that go through our program, it's a 3-week program. It's $30,000 to $40,000. People can't afford that. Hyperbaric oxygen. There's a program up the street here that it's gone down to about 18,000 for 40 dives, and none of that is covered by insurance. So unless we get healthcare reform, we're not dealing with or able to deal with the population at large that could benefit from the tremendous amount of modalities that are not embraced right now in mainstream medicine. I think another thing that's an absolute imperative, and that is change curriculums in med schools and in other allied health professions, because I think until you know what the underlying causes are of an invisible wound, you'll not be able to treat you'll be treating the symptoms, not because of what their actual baseline or underlying causes are. And the last one is with all of the veterans that come through that have had any kind of trauma while in the military, that they absolutely should apply for VA disability. So that, in a nutshell, concludes my presentation. I'd be happy to entertain questions, or if anybody ever wants to get a hold of me, you have my contact information. With that, I'll turn it back over to you, Bill. Look at the chat.
Okay. First of all, let's take a look at the chat here and see if we have any questions.
I'm going to put down the next summit that is coming up in Tampa. I'm going to put the link to. That's the one that I had met Mark at last year. There's a second annual summit, a subconcussive summit, and it's at no cost. And I really would encourage people to attend. There's a lot of exceptional speakers, and I think Mark's speaking again this year as well. And it's in, I think it's the 3rd and 4th of September. So for all those that are on this, if there's an interest in that, please take a look at that link and feel free to RSVP.
Yeah. So we got Dr. Joni Collins said she has something called the Time Machine from CSN. I'm not familiar with what that is. Do you know what that is? Or Dr. Collins, if you're on.
Hi, how are you? Thank you so much.
Enlighten us.
So Cell Surgical Network, I'm trying to put on my camera here, sorry. It's me, but who cares? I'm a PA, a physician assistant, and a doctor of osteopathic medical science. It's a new branch for PAs. There's about 100 of us in the country. But in 2020, during COVID, I was really blessed to meet Sean Berman, who is the son of Dr. Mark Berman, who's passed, unfortunately, during COVID. But his partner, Dr. Elliot Lander, they both had been working extensively in research for fat stem cell, or using your own fat. And seeing healing. And so this actual, device, it's a glorified centrifuge, but it has different pistons to clean, the adipose, and minimally manipulated, all the blah, blah that you have to follow. Long story short, ended up helping my dad. My dad had a stroke. My partnering physician, we used his, adipose, or, mesenchymal stem cell, and mesenchymal. So the thing that I think we don't touch on is that we age every day, and it's not a one and done, and inflammation is everything. So at my office, I'm under an aesthetic umbrella, so it's in my scope, but it's optimizing the patient on a cellular level, epigenetics, genetics, certain biomarkers. But inflammation is the key to everything. And so I put in the links here how this connects to TBI, PTSD, and blast injury. And Sean Berman, Dr. Berman, who passed away, his son, did clinical research on this, and we see improvement with it. So my life song is hopefully down the road that I will be able to write a grant and get help to be able to have a center for this, because I really believe in it. And I have something called a vibe bed. It's a bioharmonic bed that even helps with neuroplasticity. So I use it in my patients. Actually use it for my daughter. That's how I found out about it. But if you all have a chance, look into something. I don't work for them. I'm an affiliate with Cell Surgical Network, but there's something called L2 Bio. And you can actually send off about 5 teaspoons of adipose, and they can store it to have it on call. And it's your own cells. So I think it's just pretty neat to see that, but also optimizing it, knowing that we age every day, inflammation is repetitive, and so it will need to be treated more than once. So there's so many things I don't know, but I'm definitely highly passionate about this, and I'm just thankful for this talk, because there's so many people that really need help.
Absolutely.
Okay, do we have your?
I have go ahead, Bill.
Go ahead. Go ahead. Go ahead, Michael. Go ahead.
No, I have a friend of mine who has started some clinics. It's called We Pellet. And there's one in San Diego, one in Bradenton, Florida, one in Orlando, and they're building more over the country. And I believe they do use that time machine method. But it is definitely getting a lot of traction. But once again, it costs thousands of dollars for people to go through these kinds of programs, and your average middle class American can ill afford to do that, unfortunately.
So L2 bios, it's actually just an adipose biopsy. So it's about $500. So there's something definitely affordable that's out there. Just if you all research into it, it'd be something maybe you could bring to your clinics.
Okay, thank you, Jen.
And I'll look into that. It's called We
Pellet. Yeah, you just do a We Pellet Google search.
Fantastic.
Yes.
Okay. Thank you so much.
And if you have any questions, you have my contact information, or if you want to send me information,
I will definitely connect with you afterwards. I really appreciate you. Thank you.
You're welcome, Jen.
And do we have your contact, Dr. Collins?
I'll put it in the chat. Thank you, guys. I also teach aesthetics and regenerative stuff, but it falls under the scope, so it's nice.
Okay. Well, it sounds like we need to have you on also. So.
Oh, I'm so thankful for you all. Thank you so much.
Okay.
You just got yourself a gig.
Yeah, that's what happens, and if you're good at it, we'll invite you back. That's even worse.
And now.
Okay. Dr. Leonard, speaking about chiropractic cervical care, has a niche, and he's encouraging our osteopathic heritage for manipulative care. He says he's tried to provide care to vets, but it's a closed system for referrals outside of their system. So, also Dr. Collins, SVF, SMSC, mesenchymal stem cells. Is that?
Yeah, and stromal vascular fracture. That's all. It's just a rich soup of, yeah.
Yeah, and so we know those of you who've listened to me drone on, you've heard me talk about opioids and testosterone deficiencies. So we're well aware of that.
Call me Captain Obvious. Sorry, I was just excited.
There's Michael's contact there, I guess. Subconcussivsummit.com. And you want to get that, Dr. Nario, so we have it. We'll put it on the newsletter. Do you have any questions, Dr. Nario, from?
Yeah. So we have some online here. So Michael, thank you so much for that great presentation. And it would have been nice if you've met one of our main guys, Joel, who's a veteran, and he speaks a lot about this type of condition. And I think Dr. Bill was one of the major players in his recovery in relation to his TBI experience. So he's an advocate for the vets, but I'm sure you're going to cross paths someday. But one of the things that was, I also want to acknowledge the VA having one of the, I guess they're branching out into integrative services also. And they have whole health, I guess, services, as they call it. So that's the name. And I learned about this during the fellowship. So as I kind of got my eyes open that the government, or the VA specifically, is starting to branch out towards integrative medicines. In your experience, what integrative approaches has been specifically being accepted by the VA, And then how can the vets utilize these resources?
Yeah, that's a great question. You know, VA has started a whole health program that any veteran can enroll in and have a life coach available to them that they can talk to, whether it be in person or virtual meetings on an ongoing basis, to be able to focus on some of those issues that have had a negative impact on a veteran's quality of life, whether it be obesity, whether it be substance abuse, sedentary diet. All of those things are incorporated in this whole health program that VA started several years ago. And I think that, you know, one of the challenges is there's a significant male elderly population in the VA healthcare system. And I think a lot of them are at a point in their life, they're just, unfortunately, they're ignorant of some of the things that would really enhance the quality of their life. So VA has been trying to market that as well, so that more of the veteran population, irrespective of age, can benefit from more preventive as opposed to reactive kinds of issues. So yeah, VA has really, I have to applaud VA in the last several years because they've become much more open to being proactive, much more open to modalities that were never embraced before. And I think that they're going to continue in that direction because I think as younger veterans use the system, their needs are different than the large elderly population that VA serves. But great question. Thank you.
Yeah, and as you mentioned a while ago, that I think I heard you saying men in the military, right? So I have patients who are also veterans, who are women. The thing here is, I don't know if this is just me, but the misconception that TBI only occurs with men who are out there. You'd be surprised that even women are more prone to actually endure TBI for the reasons that hormonal changes actually affects them more compared to men. So there is a number of VA women that I see who are also suffering from this condition. So again, those are the stereotypes that we always
Mm-hmm.
hear about. But and also another stereotype is we need to always hear about massive TBI damage. You need to have an explosion. You need to have somebody hit you in the head. Not
Yeah.
really, but there are really like small cumulative injuries in the head. Just a small hit on the head, right? Hitting your head on a pole. So these are
Mm-hmm.
really all about repetitive accumulations. So that misconception should be put out there, even not only for us assessing VA patients,
Mm-hmm.
but
Yeah.
even for our own patients out there who are going through this. And I'm sure you have most common misconceptions that you encounter also in
No,
relation to
and I
this.
think you can literally never lose consciousness and have a brain injury from subconcussive events. And I think that that's not something that is well known. The link that I sent out on this subconcussive conference, it's the first ever international speakers. It really is starting to increase the visibility of those kinds of issues that in fact cause traumatic brain injuries over time. As it relates to women veterans, about 20% of the veteran population now, are about 18 to 20 are females. It was only 2 or 3% in World War II, but they've opened up the aperture as it relates to they can serve in any designator. So you're absolutely right. A lot of female veterans are absolutely exposed and have head injuries. And a lot of them are also exposed to military sexual trauma, which
That's right.
is definitely a life changer. And oftentimes, a lot of women veterans don't even self identify as veterans because of their negative experiences serving in the military.
As you mentioned, whole health already. So this is basically the integrative medicine arm of the VA. And as we all, as us being advocates of integrative medicine, we focus on prevention. So having better brain health, brain structure, even before you go out into the field. I mean, and of course, we utilize our omegas, magnesium threonate, curcumin, all of our supplements, just to make sure that that occurs. Is that something that you're seeing that basically VA would be starting to open? I mean, not only through supplements, but acupuncture, yoga, mindfulness. So all of these other brand, I know you did mention the health coach, but Are you seeing in the future they're going to branch out towards these resources for our veterans?
Absolutely. And I can tell you firsthand from my experiences, I've had VA authorized acupuncture care for me, which is unheard of. I've had VA authorized medical massages for me, which is unheard of. So yeah, I mean the paradigm is absolutely shifting.
Right.
And if you think about it, and this is one of the things that I try to communicate when I'm talking to decision makers at high levels within VA, DoD, or any kind of health system, and that is if you can focus on the preventive component, then the quality of the person's life is going to be better, and their overall healthcare costs in a lifetime will be significantly less.
Right. Again, yes. I mean, I know this is still going to progress, but as I could see, you're one of the beneficiaries of these types of services, and as you now become the voice that
Mhm.
would now tell everybody that this really works. And here's another good question: what barriers do veterans face in seeking this type of care?
I think there's a high level of ignorance in the bureaucracy of the system is very difficult to navigate. I'm obviously a well-educated healthcare consumer, so I know where to go, what questions to ask, and if someone says no, I know how to go to the next step to hopefully get the answer that I believe is the right answer. But if you're dealing with, 22, 23-year-old kid that just served 4 years in the military that has a high school education, and they go to the VA system, it's a difficult healthcare system to navigate. And that's why one of the things I do is I'm a VP for a nonprofit that does a lot of advocacy for veterans, primarily in the community I live in, to help overcome some of those barriers. Because yeah, I mean, it's when you hit a roadblock as a 22-year-old and they say no, the likelihood is you're going to walk away, or you have a very negative experience with VA, and you say, well, the system sucks, and they go elsewhere.
Right. And also, I think education is very important here that for you as a veteran, you need to understand the symptoms of even post-concussion syndrome. Sometimes as a man, you're going to be thinking like, oh, I'm fine. I'm doing okay. This is my normal me. It's just stress. There's so many confounding factors here that education needs to be emphasized, especially to our veterans. And again, even the clinicians that are working in the VA needs to be educated about it so they can actually spread that word for the veterans to understand. So and yeah, and definitely there's so much more out there for sure. Here's another one. What prevention strategies are emphasized now to minimize TBIs for our veterans?
Well, I think I allude to the Deputy Secretary of the Department of Defense signed a policy as of the 1st of January for every new recruit that comes into the military to have a cognitive baseline test. And I think oftentimes, if you look at the behavioral traits of a lot of people that are attracted to the military, the enlisted workforce, primarily, not your best student, usually probably a subpar athlete, but they are patriotic. They come from, maybe not a very good family environment. They just want to get out of Dodge, wherever they're living. And they have a propensity probably to have some high risk behavioral traits. And so I think part of what I think is important is to understand that these are important variables that I think are that need to be factored into why there's a high suicide rate with the veteran population. But what we're trying to do is make the right decisions on who should and who shouldn't serve in the military by doing the kinds of tests prior to, so that the likelihood is if they do have an injury or an issue in the military, it's not a pre-existing condition. And while you're in uniform with that concussive baseline, anytime you are exposed, if it's a training accident, car accident, motorcycle accident, deployment, anything, is that if you have that baseline and you can repeat that test, if there's significant changes, you keep them out of the situation. To obviously, having back-to-back concussions is much greater with having long-term TBI symptoms than if it's concussion. The brain heals and weeks or months go by and you're operating and you're you're back to your baseline. So there's a lot of real positive things going on as it relates to the preventive component of serving in the military.
Right. That's a good thing you mentioned about that, because one of the things that I've heard before was the screening of like post-blast exposures. So that's definitely something that you definitely want to compare from the initial baseline. And you now will have the change. You will see that change once you actually do this the right way. And I don't know, this is my curiosity. I mean, the
Mm-hmm.
protective headgear, are these really evaluated real well? I mean, do they check that? I mean, I don't know how in terms of training, being in the field, do they wear different helmets for that? So, because that's where your protection is, it's on the head. So,
Yeah,
I'm sure you do your.
and even your hearing of the hearing tools to the degree that it's really making an impact on your safety. Yeah,
Right.
and there's a lot of research going on. In fact, there's several billions of dollars in the next budget specifically on developing protocols for brain imaging, equipment, supplies, training to help make the workforce a safer workforce.
Right. I'm sure you're not going to send your soldiers out with your bicycle helmet, so you definitely want
No.
to make sure you reinforce that. So here's I guess this is your kind of like capping off question. If you have one message that you wish every veteran would hear about TBI, what would that be?
I would say to not, if you have any type of trauma and you feel different, when I say different, those symptoms that I referenced earlier, brain fog, balance, any of those things, get an assessment, get an evaluation, and make sure that you express those issues to whoever you're speaking to from a clinical perspective. Because I think, as I think whoever said, is so many people walk around with brain fog and TBI symptoms, and they think, "Oh, that's just the way I am." If it's not the way that you once were, I mean, I've had several head injuries, and there's times when my cognitive abilities are so acute that I mean, I can't believe how much I can comprehend at a given time. But then there's times when I've had a head injury where it's like it takes a while for things to clear up. And I'm actually participating in Mark's protocol right now, and so I do think that yeah, it is, if there's changes in your behavior that include those issues that are physiological, see a doc.
Right. So that was a great answer. You win the beauty pageant for that. So, well, Michael, thank you so much. You have knocked out
You're
all my
welcome. Thank you.
questions.
Thank
Thank
you.
you.
Um, well, it's only 6:04. It's a little early for us to be saying goodnight. I mean, we can say goodnight. Would anybody be interested in a little bit of
Dr. Clearfield.
Yes, Michael.
Hello, hello, hello.
Yes, Michael.
Hi, Dr. Michael Gerber here. A few comments. I think one of the most powerful things for TBIs and post-concussion illness is a crown of thorns, where you take 1% procaine. This is old German neural therapy, been around since 1905. Of course, I learned from Klinghardt, but he learned from a lot of other German guys. But you do 1% procaine around the biggest circumference of the head, starting with the old third eye with a 2730 gauge needle, and you do a little bubble under the skin, bump, 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 around the greater circumference of the head. And it wakes up nerves that have been injured or damaged. Also, paying particular attention if there's any obvious scars, infiltrate the scars with procaine. And we've seen a great many cognitive disturbances clear up. So don't forget Crown of Thorns with 1% procaine neural therapy. It's inexpensive and it's quick. And if you do a couple of sessions a week or two apart and nothing changes, it's not worthwhile. But frequently you'll see some marvelous changes. Even, people have, automobile accidents and everyday concussions. Also, I agree with Dr. Clearfield. Everybody with head injury has hormonal deficiency, so everybody's adrenal is beat up. after head injuries. So supporting the adrenal gland is very important. And then as well as doing a nutritional supplementation for everybody, and even good old homeopathy, things even like arnica and Staphylococcus aureus for old injury and aconitum for anxiety. All these guys can be very helpful in the pie for PTSD. But neurotherapy and crown of thorns is really awesome, and it's inexpensive, and everybody can do it. So my 2 cents worth.
Okay.
I'm gonna try that out. What I do for concussions, and I see it in my population, soccer players, young girls who head balls, and so female soccer is pretty violent sport. I don't recommend it. I give them synapsin. It's RG3 with methylcobalamin, plus what's it? RG3 ginseng and nicotinamide riboside. So that's brain food, ginseng extract, and a B12, and they breathe it right up into the brain through the nose. Two sniffs, both nostrils, twice daily for about a week. And we used to be able to get intranasal BPCU 157 and TB 500, and we would do that intranasally as well. But we can't get that anymore, so we just stick with synapse and put them in the hyperbaric chamber as well. So that's what we do here.
Okay, great. And Dr. Collins writes about using PRF instead of Procaine. So platelet-rich fibrin, is that what you're alluding to?
Yes, sir. I'm just wondering if that would work because it's for inflammation and it's using your own cells. It would be, I mean, I don't think there's any studies on it, but Dr. Gerber, that would be interesting to see because it does help with inflammatory response and neuropathies. Huh.
Yeah, the issue there would be, I think, cost. I mean, Procaine cost what, the 10 bucks a bottle, it'll last you forever. And
PRF is $13. I can teach you how to do it for $13.
so, okay. All right.
Dr. Bill, your progesterone.
There you go.
After TBI.
Yeah. Okay. There you go. September. What did we say? We got Dr. Stiegel on September 9th. September 30th, Dr. Collins, you're on.
I'm on. Game on.
You're gonna September 30th, 5 p.m. You're gonna teach us PRF.
Sounds good.
For $13.
Seriously. Perfect. I'm so excited. Absolutely.
Okay. All right. This is how we do it here. What I was going to ask
Dr. Bill, don't forget your progesterone. That's the TBI remedy that you suggested before.
That is good. That's going to be my they were intrigued with that at the Androgen Society about using progesterone to stimulate testosterone production, particularly in young men. So that's going to be, I think that's going to be my my ticket in the door.
No, but for TBI, you use that for TBI. Remember?
Yeah. Oh, yeah. Mm-hmm. So, what I was going to say, since we have a few minutes, we're kind of early. Is anybody interested? I could do just maybe a half hour of hormones, TBI and hormones. Would did you give you a couple of highlights? Would you be interested in that, or do you want to go out and play? It's because it's summertime.
Go ahead.
Okay, so
everybody likes education here.
So so my presentation, Michael, is about 4 hours, but we'll cut it down to some of the essentials here. Can you see my screen at all?
No.
Not at all. Okay, let me get everything.
I mean, I think that's your screen. You were presenting the slides at Michael.
You still have my slides up there. Yep.
Okay, so stop that. Share my screen. There we go. Here's that. Okay, can you see that now?
There, yes.
Okay, I was muted. Sorry. Okay, I'm just going to give you a sort of a brief rundown of some of the hormones and what the symptoms are. This concept came about by the discovery in 1985 from some researchers in Paris about neurosteroids, and that the brain actually has its own steroidogenic pathway. It makes its own hormones, separate from the periphery. So the neurosteroids are pregnenolone, progesterone, allopregnenolone, DHEA, estradiol, progesterone, testosterone, and cortisol. So those are the neurosteroids. So progesterone and alloprogesterone and DHEA protect neurons in traumatic brain injury. They protect nerves from oxidative stress. They promote neuroregeneration. They regenerate myelin. They reduce inflammatory cytokines, and they reduce interleukins. Alzheimer's or dementia patients and TBI victims both exhibit a deficiency in allopregnenolone in their frontal lobes. Allopregnenolone is the trigger for the calming neurotransmitter. Here we go. Here's my dementia. Michael, what's the calming neurotransmitter? Not glutamine. What's the GABA? GABA. So, all right, and here are the concentrations of again the neurosteroids. This is in the periphery here, and as you can see in the brain, the postmenopausal brain in the luteal phase, progesterone and pregnenolone, you can see is much more concentrated in the brain and in the periphery. Progesterone prevents neuronal loss. It reduces myelin loss. It attenuates interleukin 1B and TNF alpha. Pregnenolone regulates transmission in the hippocampus. Pregnenolone is your hormone of memory and learning. We measure this on every one of our patients, and it really correlates quite nicely with the lab values. 90 to 110, and the units escape me at the moment, is our sweet spot there. Post-TBI depression, stress, and memory processes are related to behavioral aspects of the neuroactive steroid hormones. And what you'll find is that the typical, and Michael, you can relate to this, I'm sure, the typical SSRIs, the anti-anxiety agents, antidepressive agents, usually don't work very well in these conditions, and the practitioners add in two medications, three medications, four medications, and then you have to add in two or three to counteract the side effects. High doses of anti-anxiety agents and antidepressants suppress brain hormone production in the brain. Most commonly, LH, FSH, and growth hormone are affected. Here, Dr. Nario, here's your zinc-copper ratio. Okay, and zinc-copper ratio becomes unbalanced with an associated accumulation of albumin, or rather aluminum, in the brain. Decreased zinc production increases the production of beta amyloid. And our dose here is 30 to 60 milligrams of zinc with a concurrent 15 to 1 dose of copper. This is a chart of the percentage of change in hormone levels within in the white here is 24 within 24 hours of a traumatic brain injury, and the black here is it was 96 hours of a traumatic brain injury, and this is percentage of patients. And as you can see here, cortisol levels will decrease by more than 50%, free T3 by more than 50%. This is in males. Testosterone, almost 100% of the males have some change in testosterone levels, and LH also will decrease by 50%. So you can see the hormones are quite affected. The first hormone that is affected is growth hormone. That's the first and most common. With an acute injury, it's at about a 20% rate of affected growth hormone, and if left unchecked, in 12 months, it actually increases to 35 to 40% of survivors have a growth hormone deficiency. Growth hormone defects result in issues with memory, concentration, starting projects easily or not, finishing projects easily or not, what we call executive function. anxiety, and obsessive compulsive tendencies. And you think about your veteran who's had a head injury and they have all of these all of these symptoms, and they're given all sorts of medications, and the growth hormone's not looked at. Traumatic brain injury with growth hormone deficiency results in rapid weight gain, depression, different difficulty with attention, memory, emotion, moods changes, depression, and executive functioning. And these are easily measured. I mean, these are not things that are exotically measured. And we have a cash lab that we deal with, and it's $350 for the whole set, for 10 hormones. Pretty much the same thing. Improvements in interleukin 6, interleukin 1, C-reactive protein, and homocysteine when we normalize growth hormone. And again, concentration, memory, fatigue, lean body mass. So lab values, growth hormone itself, I don't usually measure this all the time. I use IGF-1. Growth hormone is difficult to get an accurate measurement. You have to do it within a certain period of time from the time it's drawn. The lab tech has to be careful with the tubes. The cells are easy to break, and the growth hormone levels are not very accurate. IGF-1 is a little bit more stable. You want that about 200 to 250. IGF-1 BP3, because we're already getting into the weeds. That's a transport protein, and you want that about 4,000. Here's our remedies here, and we usually start with the peptides first. So sermorelin, which is a growth hormone releasing hormone, and with a gonadotropin releasing hormone. We usually use CJC 1295, which is a newer one. With drug affinity complex DAC, that's a once a week dose, or without it, it's a 5-day-a-week dose. There's homeopathic sprays that will raise testosterone, or rather growth hormone levels, by about 15 to 20% over about 3 months. And there's something called ibutamorin, or MK677, which is a pill form. 10 milligrams for females, 25 for males. Thyroid, 10 to 30% of TBI patients develop hypothyroidism. We end up with an elevated reverse T3. This is usually reflects stress and an increase in cortisol also, and this is from the neurodegenerative issues that happen. We get a decrease in total T3. Usually T4 is either not affected or increased slightly. We like the combinations, the T3, T4 combinations, either the compounded ones. There's 2 commercial ones that are available, the Still Armor and NP Thyroid. I tend to use the NP Thyroid. The Armor has some gluten in it and some dairy in its coating, and so some of the patients are kind of sensitive to that. Symptoms of hypothyroidism, 98% of the time it's going to be hypothyroid that you're going to see. Dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long, and the outer third of the eyebrow will thin out, so those are the symptoms of hypothyroidism. There's cognitive issues with low thyroid, and psychosis with low thyroid. Cortisol levels, you'll get an increase in the cortisol response in the AM cortisol response, with an increase in ACTH, an increase in cortisol, and there's a corresponding production of reverse T3. About 90 to 95% of the time when reverse T3 is elevated, it's due to elevated cortisol. We use that as a screen. I know a lot of folks use the 4-point cortisol saliva test, which is probably the most accurate. But this is a good screen. It only costs about $10. The saliva test goes anywhere from 90 to 200. It's usually not covered by anybody. The symptoms here would be when your patients wake up, they're tired. They need something to keep them going in the mid-morning. They have fatigue in the afternoon. They're exhausted by dinner time. But later at night, they get a second wind, and they get they're wide awake, and that's when they do their best work or their best thinking at 8 o'clock, 9 o'clock, 10 o'clock. Then they have trouble sleeping, and there's usually sugar and salt cravings that go with it. Cortisol can be tempered with DHEA. So there's a DHEA or cortisol DHEA ratio that you can calculate. And when cortisol levels are high, DHEA levels are usually low, and anywhere from 10 to 25 milligrams of DHEA can usually at least bring about a temporary relief from high cortisol level. Testosterone is one of the main hormones, and cognitive functions, deals with mood stabilizations, motivation, strength, energy. Deficiencies result in depression, fatigue, suicide ideation. This is where the suicide comes from. You'll see testosterone deficiency. Adequate testosterone will attenuate inflammatory cytokines. That protects against mitochondrial dysfunction and improves seizure control. And testosterone and depression post TBI. So your patients are at risk for testosterone induced depression when the total testosterone is less than 300, and you're going to get a frank depression when the testosterone's at 150. That's for total. For the free, it's about half the level of each of that. So, and here's that. So the depression is 147, free of 3.0. For females, it's 22 and 11 for the risk and depression, and free is 1 and 0.5. So Michael talked about suicide. It's the 10th leading cause of death in the U.S., and there's a direct relationship between depression and suicide. Men are 4 times the risk of the suicide than women. Suicide attempts are inversely related to testosterone levels. And I got this statistic from Dr. Davidson, who always speaks about suicide at the NOMA conferences. And he says that the peak years for men are 80 to 90 and women 50 to 65. And so I'll leave it at that. Testosterone is an anti-anxiety agent. It improves cognitive function. And the other hormone you want to look at is prolactin. Low prolactin levels are a tip-off that the patients have some treatment-resistant either anxiety or depression. High dopamine levels inhibit prolactin, and the level that you want to see of prolactin is greater than 6.0. Normal is 11 to 14, and 50, 60, 70, that's where you get your pituitary adenomas. I'll quit here, or I'll quit after some estrogen here. So estrogen maintains blood flow to the brain. So those of us that were doing, testosterone replacement and early on, and we were getting testosterone levels to 1500 and estradiol levels to 0, realized that we were ending up with memory loss and balance issues and hearing issues and tinnitus. So adequate estrogen lowers the risk of PTSD after trauma. It's a pain modulator that prevents cell death. It will actually, so adequate estrogen, and if you increase estrogen levels, will increase HDL cholesterol. As far as I know, there's still no drugs or supplements that will do that, at least consistently. Estradiol has properties similar to atypical antipsychotics, and it influences dopamine, serotonin, and glutamine. Estradiol leads to decreased production of testosterone, DHEA, progesterone, and pregnenolone. Remember, estradiol is those of us who remember the honeymooners is sort of the Ralph Cramden of hormones. It's always running around. It's the get-rich-quick scheme, and it causes all sorts of havoc. Progesterone is your balancing agent. It's Alice who calms things down. Progesterone, as we discussed earlier, reduces myelin sheath loss. It attenuates interleukin 1b, TNF alpha, and it prevents neuronal blood loss, neuronal loss. 8 milligrams per kilogram IV within 24 hours of traumatic brain injury decreases traumatic brain injury deaths within 30 days by up to 50%. we calculate it this way. I'm not going to get into the weeds here. It's part of our class. DHEA, like I said, protects against cortisol catabolism, and when cortisol levels are high, stress levels are high, just a low dose of DHEA, 10 to 25 milligrams is a really nice and easy way to sort of counteract that. So DHEA promotes weight loss. It's sort of a mini testosterone. It increases brain function. It increases lean body mass. It helps one deal with stress. It lowers triglycerides. Pregnenolone is your hormone of memory. It's an anti-aging. It's neuroprotective. It improves mental wellness. It enhances memory and cognition. It is anti-fatigue, improves psychomotor performance. It lowers excess cholesterol. It's an anti-arthritic, and it's a mood elevator. So allopregnenolone is a metabolite. Decreased allopregnenolone will create an excited state, and it will end up with either panic attacks, anxiety, major depression, and long-term Alzheimer's disease. Hormones used to treat depression: growth hormone, thyroid, testosterone. Estrogen is an adjunct that not good as a standalone. Pregnenolone and DHEA. These are within, as I mentioned before, within 3 and 12 months of anterior pituitary insufficiency due to traumatic brain injury. All hormone deficits within 3 months is in the purple, is at 56% of patients, and within a year later, if left untreated, at 36%. The gonadotropins at 32% and 21%, and ACTH 19 and 9. And as you can see, growth hormone, actually you get an increase in over a year of growth hormone deficiency over a year. There are laboratory here, so I'm going to leave it at that. I gave you just sort of a brief overview of some of the hormones and how they interact with during traumatic brain injury. We have other lectures on psychiatric issues, and we can always fill in on those. So I hope that sort of maybe even enhances a little bit what Michael was saying. And anybody have any questions about anything? And so
there's a chat question for you.
Okay. How much DHEA? So 10 milligrams for females, 25 for males, is usually enough for cortisol. You can go up to 25 for females and 100 if you're not getting the results that you want. So that would be the dose there. Okay.
One of the things that I encounter clinically, other clinicians kind of thought that when you give pregnenolone, it will downstream to estrogen, testosterone, because when you look at the metabolism, it really does not. So for just clinical purposes, yeah, just make sure that you listen to the lecture. It's more for brain functioning.
Mm-hmm.
And it does make logical sense that it does trickle down, but unfortunately, it does not increase the other hormones.
No, it does seem to have a little bit of effect on blood sugar, though. So keep an eye on the patient's blood sugars, okay? Because it can raise it a little bit. Okay, not a whole lot, but a little bit. Okay, so that's our TBI overview from Michael. Thank you so much. I have Ross Pelton on next week. I don't have a topic from him yet, so it'll be a mystery surprise. And we've had Ross on before with rapamycin and in the microbiome, so he'll have something good for us. I'm sure. Anybody have Mike, Robert, Dr. Quinn? You got anything from the research group?
Yeah. Can you hear me okay?
Yep. Mm-hmm.
I've been having trouble with the microphone here. Yeah, we did a lot. We actually had 2 meetings this past Saturday. The first one was on what we call the molecule that is presented by Dr. Dimitri and the actual inventor, having to do with detoxification of heavy metals. They presented a bunch of studies and things like that. And what we're going to do is add that to the apothecary formulary. For those of you who remember what that is, we're developing tribal entities under First Nations Medical Board for clinics to be able to receive benefits as being a tribal entity. The sanctity of those is put forth by the federal government. And so it's kind of cutting edge type of stuff. We're adding some interesting things to the formulary, and this happens to be one. It's NMBI, amaramide. They went through an FDA process or are still going through that, but that doesn't look so promising. So they came to us, and along the lines of what Dr. Burgess was talking about for research and things like that, we may be able to do some research on this. They've done a bunch, but we'll do patient outcomes if we can. That was one thing. The second one was presented by Dr. David Shangaris. Many of us know him. He is a big proponent of conjugated linoleic acid for a lot of different treatments. And one thing that he stressed was brain health. And he mentioned something in passing that for TBI, the combination of progesterone and CLA, like in an 8% solution, can actually help with some of the symptoms of TBI. So there's another treatment right there. He went on and spoke highly of a lot of different things that this did, and where to get this, and how basically it was sourced from safflower. And he's looking for, I guess, some of the tribal entities to grow that for him. This is going worldwide. He's got some amazing studies. So we covered all of that. I'm not sure, if there was anything else. It was extensive. We ended up meeting for about 4 hours in total. So Saturdays are becoming quite the monster, as I say. We're covering so many things and doing so many new cutting edge things. People are invited if they would like to listen in or even present type of things. That's wonderful. They can get a hold of me, or get a hold of you or Dr. Nario and give them my information. Mm-hmm. But that's kind of what we did. I don't know if Dr. Tano is on here. I didn't notice, but if he is,
okay. Yeah, I'm here. But
I
think Dr. Quinn covered all the bases. In terms of education, we're still in progress. Nothing really major happened there. But the presentation by Dr. Shangaris was one of the lifeline of the whole thing last Saturday.
Yes. And Dr. Tano, once again, please, I'm now seeing a lot of articles on this, on how AI is ignoring holistic or alternative or whatever you want to call it, healthcare, right. A lot of the things that we agree with, and everybody. Dr. Tano put out a phenomenal book on decoding AI. I mentioned last time decoding the AI bias in healthcare. I just saw something that says Google is now doing the same thing. So whatever powers are out there, they're strongly leading people to the conventional treatments. And I encourage people to take a look at Dr. Tano's his book on this. Is there a video with that, Dr. Tano?
No, not the video, but the book was with Dr. Anthony James, and it's on Amazon. Yes.
Okay. Yeah. And I mentioned last week, I think I saw it as a #7 bestseller. You can pick up a free Kindle version if that's right still.
Right.
And that is a great way. Now, what Dr. Tano has done with this is it's extensive, but if there's certain chapters or things that you're interested in, you can go to that, click on that, and you can read the information on that. So it's a fantastic reference. And again, now I'm seeing a lot of people complaining about AI bias in this arena. And so again, I encourage people to explore that. Those of us who use AI for various things need to be aware of that.
And by the way, in September, I think we scheduled, Dr. Anthony's scheduled to speak about this at Dr. Clearfield's meeting in September. I don't know.
Who is speaking?
Dr. James, Anthony James.
Oh, Anthony James. That's right. Yeah, that's right. Yeah, he's an interesting guy. Interesting guy. There's a couple of other people who have maybe expressed some interest in participating. Dr. Shangaris might be one as well. So we'll see. And then maybe Dr. Dimitri.
get me their contacts, and we're happy to have them. So
Okay, so we're progressing at light speed again, thanks to Dr. Burgess for setting this up, and as a subgroup, we're just going and going and going. So I'm really proud of everybody's efforts.
Okay. We're hoping we're going to get Dr. Weil on, right, Dr. Nario?
I'm working on it.
Okay. All right. Okay. All right. Anybody else have any comments or questions, or got any?
Dr. Quinn, I'm just curious, how do you navigate towards that bias that there is, you can't find integrated material, I guess, when you do AI? How do you navigate? I mean, just, yeah, I'm just curious. That's a curious question.
Dr. Tano, do you have a comment on that?
Yeah, so because the traditional medicine or natural medicines are not well covered in the literature, or at least the conventional medicine takeover, but not covering that at length in whatever they do. They don't references, they don't do anything. So it appears that all the things that have been written for thousands of years, Ayurveda, traditional Chinese medicine, all of these, the AI training does not include that. And so if the AI training does not include that, it's like it doesn't exist. So if you were to look for something deep in AI about Ayurveda or any of the traditional medicine, it would not show you. So it's like the groups are left behind, millions or billions of people are left behind, just catering to a small minority that does with allopathic medicine. That's basically that.
Okay, and what to do about that, Dr. Nario? I kind of put in terms terms that I want to use, whether it be holistic, natural, indigenous, things like that. If I'm looking for anything, I want to include that term.
So you just have to be specific, basically.
Yeah,
Right.
and I think we're all finding that you can be pretty specific with some of this AI stuff and get some amazing things. And again, I caution people to watch out for the references because sometimes they're not accurate.
Gotcha.
So I just went on ChatGPT and I asked it if it was trained on Ayurvedic medicine, and all I'm getting back is a dot. Not getting any answer. Nothing.
Yeah, that's right. So yeah, that's billions of people left behind.
Yeah.
So
So again, I encourage people to check out. I mean, this is what all of us here on these groups understand, that there are treatment modalities that aren't quote unquote mainstream. So I encourage people to check out this book and see what it's all about and follow what's happening. I don't know what can be done about Google and all of this kind of stuff, leaving all of this out. I have no clue.
Okay. Okay. Well, you got your marching orders.
Hey, Bill.
Yeah.
Bill, Adam Crouch here. Could you send me or email me the contact information you mentioned you had last week for the gentleman about rapamycin?
Yeah, he's going to be on next week, as a matter of fact. Yeah, I'll send it to you.
Oh,
yeah.
All right. Thank you.
Okay, we'll do. Okay. Anybody else? Okay. All right then. We'll have the video up as soon as I get it done, and we'll see you next same time, same station, 5 p.m. next Tuesday. We'll have Ross Pelton on, and I don't know what the topic is, so we'll find out together. And Dr. Collins, thank you for being with us and participating, and we look forward to hearing from you.
I really appreciate all of you. Thank you so much.
Bring a couple of friends along too, so we can
I got a couple.
Yeah. Bring
Awesome.
a couple of friends along. We sort of expand our reach.
Fantastic.
Okay.
Absolutely.
Can I say something real fast? Oh, I'm so sorry.
Yeah, go ahead.
To Dr. Collins, you asked about how we can access the formulary at the tribal site. The formulary is not complete. It's a definite work in progress. It's taking time to put everything together. But once it is, I will let people know here how to get it.
Yes, and I'd love to connect with you about that on Hepatica laminaris, and we'll talk about that later. So thank you
Okay.
so much. Okay.
Thank you.
Thank you all.
All right. Thank you, everybody. Thank you. And thank you all for supporting us. We'll see you again next week.